You're standing in the doorway with one shoe on, keys in hand, while light from the window suddenly feels too sharp to trust. You know the meeting will go on without you. The birthday dinner might too. Migraine does not just hurt. It steals whole pieces of a day. For years, many people were told prevention meant trying older medicines first, then waiting through sleepiness, weight changes, or brain fog. Migraine is a neurologic disease, not a personality flaw, and prevention is often considered when attacks repeatedly disrupt normal life. That old path made sense once. Doctors used blood pressure drugs, seizure medicines, and antidepressants because some also reduce migraine days. In March 2024, the American Headache Society changed the map. CGRP-targeting therapies can be considered a first-line option for prevention. That sounds bureaucratic, but if you lose work days, parenting hours, or weekends to migraine, it may feel like a door finally opening. CGRP stands for calcitonin gene-related peptide, a signaling molecule involved in pain pathways and blood vessel changes during migraine. During a migraine attack, CGRP levels can rise, and blocking that signal has been associated with fewer migraine days for many patients. Coftly. This is the big difference. CGRP treatments were designed around migraine biology, not borrowed from a completely different condition. AHS emphasizes these are a first-line option, not the only first choice, and not the right fit for every person. The update cited substantial evidence for effectiveness, tolerability, and safety across CGRP monoclonal antibodies and preventative gepants. The first CGRP monoclonal antibodies became available in 2018, giving clinicians migraine-specific preventive tools for the first time. The AHS statement names iranomab, framinizumab, galcanezumab, eptinizumab, rimigapant, and adagrasib among supported CGRP-targeting options. A CMAJ review says prevention is commonly considered at 4 or more migraine headache days monthly, or 2 with substantial disability. That disability part matters. 2 attacks can be enough if they erase caregiving, school, work, or basic daily function. Picture Maya. She has 6 migraine days a month, not daily, but enough to miss deadlines, dim lights, and cancel plans. Before her appointment, she tracks migraine days, disability days, rescue medication use, sleep changes, menstrual timing, and likely triggers for 1 month. Older preventives can still work, especially when another condition also benefits, like high blood pressure, insomnia, or anxiety symptoms. But the CMAJ review reported low persistence with older oral preventives, 26 to 29% at 6 months, 17 to 20% at 12. Persistence is a dry word for something human. People stop treatments when the trade-off feels worse than the migraine pattern. Targeted does not mean risk-free. The AHS statement still frames CGRP choices through safety, tolerability, patient history, and shared decision-making. So the better question is not, what is newest? It is which prevention strategy matches your migraine pattern and your body. At the visit, consider asking, what are my realistic options, what benefits would count, and what trade-offs should I watch? AHS educational materials see more than 150 new clinical and real-world studies supported the first-line option shift. Pause. That matters because step therapy often made patients prove they struggled on older drugs before insurance considered migraine-specific prevention. Insurance may still ask for that history. If it does, your clinician may be able to cite the AHS position statement in an appeal. The American Migraine Foundation's 2024 recap also highlighted access, advocacy, and continued research as central migraine care themes. Access is not a side note. A treatment you cannot afford, refill, or get approved is not a plan yet. One approach is to ask about prior authorization, copay programs, documentation, and what happens if the first request is denied. CGRP monoclonal antibodies are typically given by injection or infusion on schedules that differ by medication. Some people like less frequent dosing. Others prefer a daily pill. Convenience can matter because prevention only helps when you can stay with it. If needles worry you, say that plainly. If daily medication feels harder, say that too. Preferences are useful clinical information. Preventive gepants, including rimegepant and atogepant, are oral CGRP pathway options supported in the AHS review. Here is the nuance. A targeted medication can still affect systems beyond the head because CGRP works throughout the body. Bring up constipation before starting, especially if you already struggle with it. Your clinician may suggest monitoring, diet steps, or another option. Blood pressure deserves attention too, because CGRP has roles in blood vessel function, and some patients may need closer monitoring. If you have hypertension, vascular disease, or new chest symptoms, consider asking how that history shapes the prevention choice. The CMAJ review notes preventative selection should account for comorbidities, contraindications, patient preference, and potential adverse effects. Pregnancy planning is another early conversation. CGRP therapies may not be preferred when trying to conceive, pregnant, or breastfeeding. Evidence for long-term CGRP safety continues to accumulate, but pregnancy data remain more limited than data for many established medications. This content is for informational purposes only and is not a substitute for professional medical advice. Always consult your doctor or a qualified healthcare provider before making changes to your health routine. Maya asks about pregnancy, constipation, blood pressure, and cost. The visit changes from permission-seeking to decision-making. Try this phrase: I know older medicines can help, but can we discuss CGRP prevention as a first-line option for me? Then pause. Let your clinician explain fit, risks, access steps, and backup plans. You are not demanding, you are participating. AHS leaders have clarified they are not saying CGRP therapies must be first for everyone, only that they should not require prior failures. That distinction protects choice. Some people will still pick topiramate, propranolol, amitriptyline, or another established preventive. For example, propranolol may make sense if migraine and certain heart-related conditions overlap, but only after clinician review. Topiramate may help some patients, but it can be a poor fit with pregnancy plans or certain cognitive side effects. Amitriptyline may be considered when sleep is also a problem, though drowsiness and weight changes can matter for daily life. So this is not old versus new. It is borrowed tools plus migraine-specific tools chosen with less forced suffering. Bring a simple outcome target: fewer migraine days, fewer severe days, less acute medication, or faster return to normal activity. Clinical migraine trials often measure changes in monthly migraine days, but your personal win may be more functional than numerical. Warmly, maybe success means making the school pickup, finishing a shift, or staying at dinner when dessert arrives. Also track acute medication days. If they climb, ask about medication overuse headache and whether prevention should change. The CMAG review includes acute medication overuse as one reason prevention may be appropriate in migraine care. If you start a preventive, ask when to judge it. Some plans need weeks or months before the pattern becomes clear. Ask what to do if constipation appears, blood pressure changes, attacks worsen, or you miss a scheduled dose. If cost blocks treatment, consider asking about samples, manufacturer assistance, formulary alternatives, or an appeal letter referencing the AHS update. None of this makes migraine simple. It makes the starting line more honest for people who have already lost enough time. The 2024 AHS statement was published in Headache and represents an expert position based on the available evidence. Expert guidance is not a prescription for you, it is a stronger basis for a better conversation. Before your next appointment, write 3 things: migraine days, what migraine costs you, and what trade-offs you are unwilling to make. That last one matters. Fatigue, brain fog, constipation, price, pregnancy plans, and blood pressure are not small details. One realistic goal is not never having another attack. It is fewer stolen days, less panic, and a plan that fits your actual life. AHS materials describe the shift as improving access to treatments with strong evidence for efficacy, tolerability, and adherence. For Maya, that means she does not have to perform failure before discussing a migraine-specific preventive. If this helped you frame your next conversation, consider liking or subscribing. It helps more people find evidence-based health guidance. And if you are in the dark room today, start smaller. Hydrate if you can. Eat if you can. Ask for help. Then, when the fog lifts, bring the question back. Could prevention start with a therapy designed for migraine biology? The current AHS answer is yes. It can be considered without requiring several older medication failures first. That does not remove every barrier, but it changes the conversation from earning access to choosing care. Migraine already takes enough from the calendar. Prevention should begin with evidence, honesty, and a plan built around your life.